Good evening and welcome to our Learn and Share conference call. I'm Russ Derry, Director of Education for Epilepsy Foundation of Michigan, and I'll be moderating this discussion. The topic for this evening is childhood epilepsy syndromes, diagnosis, treatment, and prognosis, and we're pleased to have as our speaker Dr. Alexandra Shaw, a pediatric epileptologist with the Comprehensive Epilepsy Center at Beaumont Children's Hospital. So Dr. Shaw, can you briefly share your clinical and research interests and describe your experience with this topic?
Sure thing, Russ. So my clinical areas of interest include epilepsy from more straightforward presentations to some of the the most complex and intractable cases that we might come across. And so I enjoy seeing children anywhere within the range of that spectrum and at either end. Specifically within that, I have interests in the use of dietary therapies, namely the ketogenic diet, the modified Atkins diet, and other types of diets to help with seizure control. I also happen to be interested in neurology education, and so I'm actually the director of pediatric neurology education for the residents and medical students here at Beaumont. And another interest of mine includes the impact that epilepsy has on family members, including a patient specifically. So that might be parents and siblings and any other loved one who's taking care of a child with epilepsy.
Great. So thank you for joining us this evening. In addition to there being numerous types of seizures, there's also many different types of epilepsy. So when a child's epilepsy has a certain set of features, this epilepsy may end up being classified as a specific epilepsy syndrome. Can you talk about the types of features that can contribute to the diagnosis of an epilepsy syndrome?
Certainly, it's a great question. So epilepsy syndromes, or electroclinical syndromes, as we might describe them, are a group of clinical entities that are very reliably identified by a cluster of both clinical characteristics, which is to say characteristics that we learn about in a clinical intake with patients based on their history and their physical examination, and then also features of their EEGs as well. More specifically, what I mean by that is the age at which seizures begin, the specific types of seizures that a child might have, their developmental status before seizures began, and their developmental status since the seizures started. Again, features of their physical examination, features of their EEG. There are a myriad kind of ways of interpreting or parsing out an EEG, and so without getting too technical there, I'll just say that there are a number of different patterns and features that we look for on an EEG that can help us to categorize epilepsy. And what's so powerful about the concept of the electroclinical syndrome is that with those features, we can successfully identify an underlying cause and also rapidly understand what types of treatments are going to be most effective, and also understand the prognosis for somebody's epilepsy.
Great. So what are the key benefits of having a diagnosis of a specific epilepsy syndrome? Obviously, you mentioned some of those, but just in terms of the family learning that information, what practical information do they get from that?
Certainly. Yeah, so again, these are, we have not all types of epilepsy fit into electroclinical syndromes per se, and I know we'll talk about this a little bit more later, but for the electroclinical syndromes that they do have, they help us to very promptly understand what or if any further diagnostic testing is needed, and so we get to a root cause, also called an etiology, very quickly. That root cause, that etiology, also helps us understand which types of treatments are the most effective, or which types of treatments we need to steer clear of based on whether or not they might aggravate seizures for a given child. And then we also have a very quick ability to develop a sense of prognosis, both in terms of overall seizure control, to what extent we might expect development to be affected by seizures, and whether or not there are other organ systems beyond the brain, the central nervous system, that we need to evaluate to understand whether or not they might have some symptom or some component of illness that we need to identify in addition to seizures. And so the power of the electroclinical syndrome as a clinical diagnostic tool is that it arrives at really those core management features and principles very quickly. It allows us to limit any unnecessary testing. It allows us, again, to hone in on the most effective therapies that are the least likely to cause any harm, and to help understand what the future will bring.
Okay, great. And roughly what percentage of childhood epilepsies can be characterized by a specific electroclinical syndrome?
Oh, it's a great question. I don't know that we have that stat. I certainly am the first to admit the limitations of my own knowledge. I haven't seen that number. Russ, is that something that you've seen?
I remember seeing it at some point while I was doing this discussion guide, but it was surprising low.
Okay.
Just like on a, would you say it's under 50% or over?
Yeah,
50%?
that's a good way of putting it. Yeah. I would say it is somewhere over 20 and less than 50.
Yeah, that seems consistent with what I saw at some point. So, okay. So for those cases where a child's epilepsy may not fit into a specific epilepsy syndrome, the neurologist still may be able to narrow down to some extent the type of epilepsy that the child has. For example, you might be able to differentiate between focal and generalized epilepsy, or there may be a combination of both. And if it's focal, you may be able to provide additional information on localization or the area of the brain involved. And as you referenced earlier, you may also be able to provide information on etiology or the cause of epilepsy. Can you talk about a little bit about these ways of further specifying a child's epilepsy when an electroclinical syndrome is not apparent, and the value of that type of information?
Certainly. So, I think about the main subtypes of underlying causes of epilepsy as, roughly falling into 6 big categories. This is not in any order other than just from the top of my head. The first one being structural or architectural causes of seizures and epilepsy. These might be something either that you are born with, something like a malformation of cortical development. They might be a result of some sort of alteration of the structure of the brain that occurs somewhere around the time of birth. For instance, something like a neonatal ischemic stroke or hemorrhage, or they might be due to structural brain injuries that occur later on in life. Something, for instance, related to a traumatic brain injury, like something that might occur in a car accident, or something like that. The second big subtype would be a genetic type of epilepsy. This ranges anything from entire chromosomes being added or deleted from somebody's genetic information to just larger portions of the chromosome that are either deleted or duplicated, meaning having an additional component of them. Or they might be so small that they might be on the order of a single gene variant. So something's zooming all the way down into the protein structure of DNA that might alter neuronal cellular function in a way that makes seizures more likely to be generated. The third main subtype that I think about is metabolic causes of epilepsy. These are very uncommon overall in the population. They include basically changes in the way that our cells, this is on a cellular level, process the three basic fuel types, meaning protein, glucose, and fat. So this does not relate to, say, the types of foods that we put into our stomach and how our stomach and intestines process them, but how our cells are actually breaking down those nutritional subcomponents and whether or not they're able to. The fourth subtype that I think about is mitochondrial subtypes of epilepsy. The mitochondria is an organelle, essentially, which means it is a structure that lives within each one of our cells. So each one of our cells has many mitochondria in it. An easy way to think about them is that they act as energy factories, if you will, within the cell. They help our cells process and store and create energy to help our cells do all of the different things that they need to do to promote our health and well-being. And there are a number of different ways in which mitochondria might be, their function might be affected that can cause seizures. A fifth subtype of epilepsy is an autoimmune type of epilepsy, by which I mean epilepsy that is caused by one of our autoantibodies, meaning a part of our natural immune system that accidentally or suddenly begins to mistake part of the central nervous system, whether it's a neuron or some other component of it, mistakes it for something foreign or something that needs to be removed. And so it creates an autoimmune disease. And seizures and epilepsy can be one component of the expression of that disease. The sixth and final subtype that I think of in terms of causes of epilepsy, or main types of epilepsy, are infectious causes. So epilepsy caused by central nervous infections, whether they are bacterial, viral, fungal, or other of the less common infections that we might have. So yeah, those would be the other types of epilepsy that I think about.
Okay, and then in most cases, are you able to determine, again, if I'm speaking of cases where there's not a clear electroclinical syndrome. In most cases, are you able to determine whether it's focal or generalized, or is that sometimes, how is that, well, I know sometimes it is unknown, but I guess how often is that unknown?
Yeah. I think we're doing a better job now as a scientific community of being able to distinguish between focal and generalized epilepsies. There are some epilepsies that have features of both, and so we understand that rarely, this would be like less than 5%, say, of epilepsies can have both features, but usually we're able to at least understand whether or not we think seizures are starting with a focal onset or generalized onset. In fact, without getting kind of too technical or out there, there's an increasing understanding or awareness of the potential that many generalized epilepsies that we thought truly had seizures with diffuse onset are probably the result of a focal origin that very rapidly propagates and spreads to involve both hemispheres diffusely and seemingly almost immediately. So I think that we're able for most children to resolve that dichotomy, and increasingly are understanding that more epilepsies are focal than we had previously imagined. Certainly, oh, go ahead, sorry.
Yeah, I was just going to say, so then presumably as diagnostic technology gets more precise over the years, we're going to have a decreasing number of epilepsies that are classified as generalized, I would guess. Yeah, I think that it won't be, a massive overhaul in terms of how we conceptualize and classify, but certainly there will be cases that we understand are focal that we maybe had previously thought of as generalized processes.
Yeah.
Okay, and what were you going to say? You were going to say something else.
Oh, I was just going to say that, overall, the estimates vary that about, despite all of our best efforts to subclassify or categorize epilepsy, despite doing a really thorough investigation with diagnostic imaging, with genetic testing, with metabolic and mitochondrial testing, autoimmune testing, looking for evidence of infection, about, anywhere from 20 to 30% of patients that we take care of we end up describing their epilepsy as epilepsy of unknown cause, because we can't find, despite all of that workup, we can't find a specific diagnosis or evidence of a specific process that's causing it.
And that percentage has gone way down from even 10 years ago, I would guess.
Yeah, it certainly has. And the main driver of that decrease is our increasing knowledge and awareness of epilepsy genetics.
Right.
That piece of the pie is shrinking mostly because our ability to identify single gene variants and even some larger genetic changes as well has increased dramatically in the last 5 to 10 years.
Right. So in those uncommon cases where the epilepsy is categorized as unknown, not only unknown cause, but unknown seizure onset, unknown epilepsy type, in those cases, how do you as an epileptologist proceed, and how do you help families deal with that ambiguity of not knowing a lot of details about that type of epilepsy?
It's a great question. So it can be difficult to have to rest with not knowing. The flip side of that, or sort of related to that, is the fact that we have, at that point, there are typically hundreds of things that we know we can confidently say are not causing somebody's epilepsy, and use the sort of inverse of that information to help us understand a number of things in terms of whether or not there might be other, any other organ systems, the health of any other organ systems involved in somebody's epilepsy. It helps us to potentially understand in sort of broader brushstrokes what types of prognosis or future development are unlikely to happen, because we have been able to rule some things out. We're actually able to very successfully select therapies for seizure control, whether they are with medications, with non-standard anti-seizure treatment like steroids or immune suppressive treatments, things like neuromodulatory devices like VNS or RNS, or even dietary therapies. We're still able to use those tools based on the types of seizures that a child has, based on the other features, their other clinical features, even if we can't pinpoint exactly what the underlying cause of their epilepsy is.
Right. Okay. So now let's talk about some specific childhood epilepsy syndromes. Now, there's no way we can cover all of them in the time that we have, so we'll focus on a few different groupings that should cover many of the more common or well-known syndromes. So let's start with the genetic generalized epilepsies. Can you talk about what these different types of epilepsies are, their prevalence, key features, treatment options, prognosis? I know it's a lot to cover, but kind of the Cliff Notes version of each one.
Yeah, I'm having flashbacks from my oral board exams, Russ. No, this is a lot of fun. So, again, this is can't overstate what a vast topic this is, and the fact that entire textbook chapters are given over to each one of these things, and so trying to maintain both a helpful aerial view, but also diving down into some details, and certainly please don't hesitate to pause me, Russ, if there's any details I've missed, and we can do the Q&A after. But the way I think about genetic generalized epilepsies is that they are types of epilepsy that emerge from or within children who are otherwise healthy medically and who otherwise have normal development. They are some of the most common types of childhood epilepsy that we see, actually. So as an example of that, probably the hallmark genetic generalized epilepsy that you might know about is childhood absence epilepsy. Childhood absence epilepsy represents anywhere from 10 to 20% of all childhood epilepsy. Its age of onset roughly is from the age of 3 to 10 years. The peak is 5 to 7. There's a slight prevalence for girls to have it as opposed to boys. About 60 to 70% of patients with childhood absence epilepsy, which I'll just call CAE if that's all right, from now on, are girls. The hallmark seizure type of this epilepsy is something called an absence seizure. This seizure type is a very sort of abrupt and complete loss of awareness of the world around you. It's typically associated with a behavioral arrest, meaning you stop what you're doing. You usually stare. You might have some other motor feature, something called an automatism associated with it, whether it is something like swallowing or licking the lips or humming or even something like being able to continue to walk or sort of use an object in a simple way. These seizures are very brief. They last, up to 10 seconds. Usually, before they are treated with medication, they're happening very, very frequently, like potentially up to several hundreds of times per day. We know that in CAE, anywhere from 20 to 40% of children can also have generalized tonic-clonic seizures or convulsions. These are more likely to be seen later on in a child's, in childhood, I should say, by which I mean in teenage years or the early 20s. The EEG that is associated with CAE is a very characteristic, something called a 3 Hertz spike and wave pattern that refers to a type of pattern we see on the EEG. We know overall CAE is an epilepsy with a very good prognosis. Anywhere from 90 to 95% of children will outgrow their epilepsy by the time they reach their early teenage years. Those that continue to have seizures beyond that time, the seizures are often easy to control with medication, let's say maybe through their teens or 20s. And there are no developmental consequences of having this type of epilepsy, meaning children are able to learn at school and perform normally in terms of their academic tasks. We know that ethosuximide or Zerontin is the most effective medication to control absences. We also know that the second and third line medications, a little bit less likely to help, but still very helpful, are Lamictal and Depakote. Those have different types of side effects that we need to navigate, which is part of what brings them down to a second and third line therapy. There are even more medications that we can use to successfully treat this beyond that, and even potentially therapies like dietary therapy. And we know, too, that CAE is a genetically determined epilepsy. We do not know, there is no single gene abnormality associated with it, but we know from kind of familial association studies that this is a genetically determined epilepsy, and we do not need to do any further testing once we're able to make this diagnosis. So that's one. So juvenile absence epilepsy, which I'll call JAE from here on out, has a lot of similar core features to CAE, just like you mentioned, Russ. What distinguishes it is that the age of seizure onset is a little later, anywhere from, let's say, 9 to 17 years of age. It's much less common, so it represents about 2% of all childhood epilepsies. More children who have it are likely to have convulsions. About 80% of children who have JAE also have convulsions in addition to absence seizures. And about 20% of children can also have myoclonic seizures, meaning just a quick muscle jerk, almost looking like a startle response. Other important differences between JAE and CAE are the prognosis. It is still an epilepsy with an overall very good prognosis, but we know that it's a little bit less likely that children will outgrow the seizures completely. For instance, it's estimated that about 60 to 80% of children will. And for those children whose seizures persist, they are more likely to require longer treatment medications than just through their teenage and early 20s. The medications we use are very similar, though, and like CAE, the underlying cause of JAE is genetic. So that is JAE. Moving on to juvenile myoclonic epilepsy, if you'd like. Mm-hmm. So juvenile myoclonic epilepsy, which I'll call JME moving forward, is another very important genetic generalized epilepsy. It represents, this is another more common epilepsy. It actually represents about 5 to 10% of all epilepsies. That's pediatric and adult combined. The age of onset is later than CAE and JAE. It actually starts at around age 10, and it begins by around age 25. It peaks in teenage years. The characteristic seizure type of JME is something called the myoclonic seizure. You can have myoclonic seizures in other types of epilepsy, and it's not JME, but it happens to be the seizure type that is required to make a diagnosis of JME. As I mentioned, these seizures are very sudden, synchronous, meaning the same on both sides, and symmetric, again, kind of referring. Synchronous refers to like the same in time, and symmetric meaning like the same on the left and right side of the body. Quick jerk of the muscles. They can occur just once and then not happen for a while, or they can occur in clusters, meaning you'll have one after the next, many within, let's say, a couple of minutes. They're most likely actually to occur in the morning. And so we often hear reports of teenagers describing that it's hard for them to, say, brush their teeth without dropping their toothbrush, or, that it's hard to drink water or juice in the morning because they'll spill things. And they might not realize, actually, that's a myoclonic seizure. And interestingly, although it's less common within JME, the seizure type that is more likely to bring a child to medical attention is a generalized tonic-clonic seizure or convulsion. These occur in about 80% of children with JME, and again are often what prompts a diagnosis of epilepsy. About 10 to 30% of patients with JME also have absence seizures. These occur less frequently than in CAE and are also short. One of the interesting and important things to note about JME is that there are a number of environmental factors that can trigger seizures. In fact, it's estimated that as many as 90% of individuals with JME have very specifically delineated triggers. The most common ones are getting poor sleep. So, adequate sleep is defined differently from person to person, but this would sort of roughly speaking be like less than 8 hours of sleep. Stress, whether that's emotional or physical. Alcohol consumption is a very potent seizure trigger for individuals with JME. And then flashing lights or having a photosensitivity to flashing lights is also a common trigger. The seizures in JME are also most likely to occur after waking up, either from a nap or in the morning after a night of sleep. Individuals with JME are more likely overall to experience some difficulty with several types of psychiatric illnesses in addition to epilepsy, specifically difficulties with anxiety and depression. This is compared to the other genetic generalized epilepsies, and so we always take great care to understand whether or not a child or a teenager, young adult could benefit from a diagnostic evaluation and support from our colleagues in psychiatry. There are some other features of JME on an EEG that set it apart from other genetic generalized epilepsies, but I won't get too much into that. Our treatment of JME, in terms of the medications that we use, is a little bit different from the other absence epilepsies that I mentioned. Specifically because we have to be able to treat not just absences, but also myoclonic seizures and convulsions. And so medications like Depakote, medications like Keppra or Zonegran, zonisamide, move a little bit higher to the top in terms of their efficacy to control seizures in this circumstance. The prognosis for individuals with JME is good in the sense that in about 60 to 90% of patients, we're able to fully control their seizures using medications. One of the things that importantly distinguishes JME from the other absence epilepsies I mentioned was that it's much less common for an individual to completely outgrow their need for medications. So estimates range that only about 5 to maybe 40% of individuals with JME are able to completely wean off of medication, but we are able to successfully control seizures in most patients with this type of epilepsy. It's estimated that about 10, maybe 15% of individuals have seizures that persist despite appropriately selected medications. So that is JME. I'm so eager to get questions. I have to admit, I don't this is a difference in terms of, I don't typically grandstand like this, so I apologize. I hope I'm not yammering on.
This is all great information. And again, this is recorded, so
good.
It's a great resource for people going forward who want to learn about these
good.
syndromes. So,
good.
Okay,
then, good.
Is the generalized tonic-clonic seizures alone, is that a common or fairly uncommon epilepsy? Great question.
That's actually a fairly uncommon epilepsy, even within the genetic generalized epilepsies. Okay. That is actually an epilepsy that, just very, very briefly in broad brushstrokes, typically emerges in teenage years. As its name would suggest, the type of seizure that we see are generalized tonic-clonic seizures or convulsions. They usually occur more rarely. And we are typically able to completely control seizures with medications. This is a subtype of epilepsy that is less likely to, that somebody is less likely to outgrow the need for medications as they move into adulthood. But we usually are able to very successfully treat the seizures.
Okay. And with all of the genetic generalized epilepsies, am I correct in assuming that essentially all of the other treatment options beyond medications, besides resective surgery and responsive neurostimulation, are all possible options? So ketogenic diet, vagus nerve stimulation, and eventually the deep brain stimulation, that all of those could potentially be used for such epilepsies if they're treatment or drug resistant?
Yeah, so great question. Wes, the traditional anti-seizure medications are the mainstay of treatment for these epilepsies. A smaller portion of these epilepsies require escalation of therapy beyond that. Dietary therapies would probably be the second most helpful type of therapies if extra therapy is needed. And usually for those therapies, something like the modified Atkins diet is the one we're more likely to find success with. mainly because remembering that children and young adults with these epilepsies have enjoyed, a range of, or an access to a full range of food and flavor. It can be very hard to suddenly very, very dramatically limit and change your diet, as any of us with, aspirational dietary changes planned around the holidays knows. And so something as restrictive as the ketogenic diet is often more of a stress and a strain and a burden for children than it is likely to be really successful in terms of suppressing seizures. And we opt instead to start with something that's less restrictive, like either the low glycemic index treatment, which is considered an adjunctive therapy, or the modified Atkins diet, which is also considered an adjunctive therapy, meaning continuing to take medication is required. But those might have some success in further controlling seizures, while being able to maintain a little bit more diversity in your diet. Right. Beyond that, very rarely we might use steroids if somebody's seizures have escalated suddenly and very dramatically, although that's very uncommon in these types of epilepsies. I would say that the role of neurostimulation is much lower in these epilepsies. Both because they're much less likely to be so refractory, and because those neurostimulation this is just a sort of a simplification. Yeah. These epilepsies don't tend to be as responsive to that type of therapy as others, mainly focal epilepsies.
Okay. All right, so another category would be symptomatic focal epilepsies, and that really accounts for a large percentage of epilepsies and can be subcategorized by the location of the seizure focus, so temporal, frontal, occipital, or parietal. So I'm not sure whether these are actually considered epilepsy syndromes. I've seen them listed as such in some places and not in others. So can you just talk a little bit about these and some of the differences, the prevalence of them, and a little bit about the differences in that occur according to what area of the brain is affected?
Another great question. So typically, although there are some electroclinical syndromes that are defined by a specific lobe of the brain, for instance, something like autosomal dominant nocturnal frontal lobe epilepsy, or autosomal, there's something called autosomal dominant epilepsy with auditory features, which is probably a temporal lobe epilepsy. We don't tend to classify focal epilepsies with a known structural abnormality causing them as an electroclinical syndrome per se. Sure.
Okay. Well, because of how common they are, can you talk about maybe the two most common types of these, whether it's, and obviously temporal is the most common, but I'm not sure what the second most common would be, but just talk a little bit about how those are identified and how understanding that you have that type of epilepsy can then determine or give you information about prognosis and treatment.
Certainly. So symptomatic focal epilepsies also, include within their umbrella many different specific etiologies or underlying causes. And so it's difficult, although, they're all considered symptomatic focal epilepsies, it's difficult to kind of corral them all into that one tent and talk about them in terms of common features, both because there are a number of underlying processes that might cause them, and also their treatment and their associated features and their prognosis relate to their specific location in terms of where they are within the lobe, or even which lobe or where in that lobe they're located. And that's mainly something that might inflect how an approach to surgery might be taken, or if surgery can be done based on the location. So just as, in terms of the most common examples of symptomatic focal epilepsies would include, for children, malformations of cortical development. You can also think about focal cortical dysplasias in this way. These are processes they're processes that occur before birth. We often don't understand exactly what the underlying cause of the malformation might be, but we're learning more and more that there's a genetic component to these, and there also could be environmental components that are sometimes able to be identified. Let's say, for instance, if during the course of gestation a mother experiences an infection of some kind, or if perhaps engaging in some lifestyle decisions that might make a brain infection to a fetus more likely. These are focal cortical dysplasias or cortical malformations affect essentially the cytological or cellular architecture of the brain, both on a microscopic level, meaning a microscope is required to see the ways in which the layering of cells and their architecture is not orderly or shaped in the way that it's expected to, or they might be macroscopic, meaning they're large enough that we can see on an MRI scan, for instance, that the folds of the brain, the sulci and gyri, are not quite what we would expect. So that's one large category. Those malformations of cortical development or focal cortical dysplasias can occur technically anywhere within the brain, either occurring, again, very, very small, so small we might not be able to see them with MRIs or on an MRI, but we might let's say, be able to identify them on a microscope or under a microscope. And based on where they're located, they present in different ways. And I'll go into that in just a sec. Probably the second or another very large an important contributor to this type of epilepsy would be a brain tumor. These are not, in children, the types of tumors that are fast-growing and aggressive tumors. They're typically actually very slow-growing, and we are usually very successful in terms of being able to resect them completely and essentially achieve a cure completely, both for the tumor and for any associated epilepsy. We know, for instance, that many tumors have around their edges areas of very, very subtle cortical dysplasia, actually. So often those two types of focal symptomatic epilepsies co-localize, or they occur within the same patient. And so as we're doing an evaluation, when we see a typically slow-growing tumor, we're always really careful to look for signs of any associated cortical dysplasia, especially in the temporal lobes. That's actually the area that's most likely to involve both of those findings, although it can occur in other places. And that's important when we make decisions about surgical resections and how large a piece of tissue, a brain tissue, we need to take out to resolve both problems. I would say that those are the two most important types of symptomatic focal epilepsies to think about. In terms of their expression, you're exactly right that their location essentially determines how the seizures look. And this, this is something that we're still, if you can imagine, we're still, as a group of clinicians, we're still learning more and more as the years pass by how to go from a description of what a seizure looks like or looking at a seizure on a video EEG to be able to understand, okay, based on these features, I think that this is the lobe of the brain that is involved in the seizure onset. Now with diagnostic technology, like invasive monitoring like stereo EEG, we're able with, with an extraordinary amount of precision, pinpoint, literally and figuratively, where a seizure is coming from within the brain from a structural process. And so that technology, as well as advancements in diagnostic imaging like 3T MRI, and now even potentially stronger magnets like 7T MRI, our ability to understand exactly where, basically to define the margins of these processes and understand how to approach them surgically is just getting better and better.
Right. And in terms of like temporal lobe epilepsy, again, which is apparently a lot more heterogeneous than I had thought based on your description, but are there common features to temporal lobe epilepsy other than the seizure types? But are there in terms of prognosis or the course of the epilepsy? Are there things that you tend to see happen, or is it pretty much all over the map in terms of what you can expect?
No, it's a great question, Russ. So, again, you can think about seizures as symptoms of some underlying process. We've talked about the many different, underlying causes of epilepsy. Seizures are one symptom of some underlying perturbation or change in brain cellular function, neuronal function. But you can also have other symptoms of that cellular dysfunction or network dysfunction that are related to explicitly essentially what the things that a certain lobe does might be. So what the function that they have is. So as an example, the temporal lobe, which does many, many different things, and in a quick overview, some of the most important things are short and long-term memories, our ability to process information, information relating to emotions. If you have something that is causing epilepsy within the temporal lobe, you might also expect to see symptoms in terms of difficulties cognitively with those other brain functions. For instance, difficulties with short or long-term memory, with information processing, and even specifically processing emotional information. Similarly, for the frontal lobe, which also does many, many different types of things, but sort of on a large-scale view, our frontal lobes are very important in terms of essentially processing. They're also processing centers, and so our ability to attend or pay attention to things in our environment, and also to ignore other things, comes from our frontal lobes. And so, if you have a process, some type of epilepsy due to a process in the frontal lobe, you might be more likely to see features that are similar to something like attention deficit disorder, just as an example of that. You might see if an epilepsy is involving the occipital lobe, or the part of the brain that coordinates visual information. You might see that somebody has some type of visual field deficit. An example of epilepsy coming from the parietal lobe might also include symptoms specific to the parietal lobe, like ability to perform mathematical calculations or to recognize faces successfully. The parietal lobe also does many, many different things. And so the other symptoms that you might see, and in some ways that affects, your prognosis, or the ways in which epilepsy impacts your life, can be related to where exactly the seizures are coming from, if they're focal in origin. In terms of, kind of a prognosis based on which specific lobe of the brain, or like the anatomic localization of seizure onset, it's a little, we see that there, I would say that it's a mixed bag. It's also harder to kind of conceptualize it in that way. There are types of frontal lobe epilepsy that can be more or less amenable to medications or surgeries. The same thing for temporal lobe epilepsy. In general, one of the important distinguishing features of something like a focal epilepsy, specifically a structural subtype, is we automatically have to think, could this patient, could this person, an individual, benefit from surgery? We know, for instance, that our ability to medically suppress seizures, and you can think about, medications are kind of chemically suppressing seizures, but they're not otherwise altering the course of somebody's epilepsy. They're not changing the fundamental disease itself. With surgery, we can potentially have an opportunity to cure epilepsy, to completely remove the underlying source and the cause of seizures. And we know that we have to do a better job of thinking of that as a community sooner. There are some situations in which we should think about it immediately, but at the very least, when some of these seizures persist, despite two appropriately selected medications at appropriate doses, we should be trying to understand whether or not they could be a surgery candidate. And that specifically, the outcomes of epilepsy surgery are variable based on which area of the brain, which lobe is involved. So our success rates in terms of achieving a cure with resective surgery are the highest when they involve the temporal lobe. Second to that, the frontal lobe, and then kind of third and fourth, if you will, the posterior areas of the brain, like the parietal or the occipital regions. An important note, though, is that there are counterexamples to all of that, those sort of larger rules, and we can have great success in the parietal lobe and in the occipital lobe in terms of resective surgeries as well.
Sure. Okay. So another category of epilepsy syndromes is self-limited childhood focal epilepsies. So can you talk about a few examples of the more common types that fall under that heading?
Certainly. This is another, so the self-limited childhood focal epilepsies, these actually have, there are many, many different names that you might hear people use when referring to these epilepsies. Another name is the benign focal epilepsies of childhood, or in Europe, they refer to this as the benign childhood seizure susceptibility syndrome. These are, overall, this is a common type of epilepsy within the pediatric population. Benign Rolandic epilepsy, also called benign childhood epilepsy with centrotemporal spikes, is the most common type. That epilepsy can begin anywhere between 1 and early teenage years, essentially, peaking between roughly age 6 and 10. This represents anywhere from, let's say, 10 to 15% of all childhood epilepsy. The characteristic seizure type for this type of epilepsy is a focal seizure that often involves one side of the face having either clonic contractions, meaning like twitches of the facial muscles there, or some type of sensory change, meaning children might describe that they feel numb or hot or tingly on one side of their face. Many of these seizures also cause a great deal of saliva to be produced, and so you might see very copious amounts of saliva coming out of the mouth. Often there is kind of a gargling or a sort of a guttural sound that's caused by these types of seizures. About 50% of them have that. About 60% of these seizures actually, children have preserved consciousness, meaning that as the seizure is going on, they're aware of what's going on around them. They may not have the ability to speak during the seizure, but they know about what's going on, and once the seizure ends, they can tell you exactly what they were feeling, and that's, as you can imagine, very moving indeed. In about 50% of children, they can also have a focal seizure that very rapidly generalizes, and they can have a generalized tonic-clonic seizure or a convulsion. This type of epilepsy is also associated with a very unique and typical feature of centrotemporal spikes, as we mentioned. It's sort of embedded in the name, that are most often seen while a child is sleeping. This type of epilepsy is also considered to be genetic in origin, although because very, very rarely we can see some mimics of benign Rolandic epilepsy, we might do an MRI scan, or we might do some type of genetic testing, depending on what other type of clinical information we get from a clinic visit of a child with benign Rolandic epilepsy. Children with benign Rolandic epilepsy, which I'll call BRE, have a very high likelihood of outgrowing their seizures. Almost 100% of children outgrow their seizures by the time they have reached their early teenage years, and potentially even earlier than that. We know that during the active phase of this epilepsy, meaning within the first year to 3 or 4 years of the seizures, children are more likely to potentially have a learning disability, either difficulties with processing or dyslexia. They're even more likely to have difficulties with speech. And so we do have to, although benign is embedded in the name as well, we do have to remind ourselves as providers that we have to look out for these things and provide help in school or with something like speech therapy if they're happening. In terms of treatment of benign Rolandic epilepsy, most often, seizures happen infrequently enough and typically occurring at night that we do not necessarily have to treat a child with medication, sort of understanding that on balance, if, let's say, you only have 1 or 2 seizures a year and they are brief and they always occur within the safety of your own home, you can argue successfully that the risk-benefit ratio tips away from daily medication treatment, which might come with potential side effects or just the burden of having to take medication every day, and tip in favor of simply providing first aid if necessary if a seizure is occurring, but not using daily medication. Again, this is also knowing that almost all children outgrow this type of epilepsy by the time they are in late childhood, early teenage years. So that's the most important, or not most important, but just most commonly occurring type of benign focal epilepsy. I would say another one called Paniatopoulos syndrome, which is kind of a mouthful, but it's named after the Greek neurologist who identified it, would be the second most common, but pretty uncommon. Very quickly, it's a type of epilepsy that involves seizures that can sometimes be difficult to understand our seizures initially because the symptoms that they generate are something called autonomic nervous system symptoms, meaning they're not coming from the part of the brain that involves coordinating motion, so they often don't cause twitching or jerking movements or body stiffening, but they might cause like repetitive vomiting or becoming very pale or simply becoming less responsive, and they last for a long time. They can last an hour, up to an hour or 2 hours. They tend to occur very rarely, and so it's a type of epilepsy that we very rarely have to treat with medication, and children, again, almost universally outgrow the seizures by their late childhood years.
Okay, great. So another large and very complex group of epilepsies are the epileptic encephalopathies. So again,
yes.
too little time to cover all of them, but can you discuss kind of the features that epileptic encephalopathies share, and then provide an overview of some of the more common or notable epilepsy syndromes that fall under that heading?
Certainly. So I would say that the most commonly occurring epileptic encephalopathies are West syndrome. I'll get into some of the details of these in just a moment, but West syndrome, something called Lennox-Gastaut syndrome, which you can think about in some ways as related to West syndrome, just something that occurs to children when they're a little bit older. And then Dravet syndrome and something called, as you mentioned, Landau-Kleffner or CSWS, or continuous spike wave in sleep. we may not have time to get into each one in terms of the details, but I think at the very least, talking about West syndrome and Lennox-Gastaut syndrome, just in terms of their more, being more prevalent, would be helpful. West syndrome, West syndrome is an epileptic encephalopathy that is characterized by a type of seizure called an infantile spasm within the infant time period. The age of onset is typically sometime between 3 and 9 months of age, although it might occur a little bit after that. Overall, this represents about 2% of epilepsy, but it represents up to a quarter of epilepsy that presents or begins in the first year of an individual's life. Again, the main seizure type is something called an infantile spasm, which is a seizure type that causes a sudden and very brief contraction. It's typically flexion, meaning the joints. If you kind of look at your arms and your elbows, when your joint gets, when the angle gets smaller, you're closing your joint or flexing it, and when it gets bigger, you're extending it. So it's typically a flexion motion of the arms and legs and neck that typically clusters, meaning it occurs multiple times within several minutes on awaking from sleep or falling asleep. It's an epilepsy that, one of the hallmarks of epileptic encephalopathies and one of the things that makes them so vexing both for families and for providers is that they are associated with varying degrees, but typically significant changes in an infant or child or older child's development and cognitive abilities. West syndrome, for instance, is associated with global developmental delay that either is observed before the seizures begin or at some point after they start. In about 90% of patients who have West syndrome, we know that the longer the seizures persist before getting access to appropriate therapies, the more significant the developmental delay becomes, which is to say, again, one of the features of an epileptic encephalopathy is that in addition to the seizures themselves, the added impetus and the pressure to try to bring about seizure control comes from the fact that developmental delay can and often does accumulate as a child grows older. So that's a very important element of that. We know that, for instance, about 75 to 85% of children who have had West syndrome will have some component of developmental delay even after their spasms might be controlled. In terms of treating the seizures themselves, what's unique and important about spasms is that they do not respond to traditional anti-seizure medications and require non-traditional non-traditional therapies, specifically immunomodulatory therapies, by which I mean steroids. An intramuscular medication called ECTH is considered the first-line therapy for spasms, unless they're being caused by something called tuberous sclerosis, which is a rare genetically determined type of epilepsy, in which case we might use vigabatrin or Sabril. The ketogenic diet is also very effective for spasm control. In terms of our ability to control seizures, we have about a 50% chance from the onset of therapy to controlling spasms within the next month or two. One of the challenges of West syndrome is that the likelihood of going on to develop other types of seizures is about 60%. And so even if you're able to successfully control the spasm, the likelihood that a baby or a child will continue to have seizures, but a different type, is unfortunately very high. The estimates range that anywhere from 20 to 50% of all children with West syndrome, or babies with West syndrome, as they grow older, their epilepsy will evolve into something called Lennox-Gastaut syndrome. And so kind of using that as a transition. Lennox-Gastaut syndrome is also an epileptic encephalopathy. It is a type of epilepsy that occurs sometime before 8 years of age, typically between 3 and 5 years of age. It accounts for about 3 to 4% of all epilepsy. And its characteristic seizure types are a collection of 3, and you really do need to have these 3 seizure types to have the diagnosis of Lennox-Gastaut syndrome, although sometimes it can be broadly applied. The first one is something called a tonic seizure, which is the most common and required for the diagnosis. These are brief kind of flexion or extensions, muscle tensions involving either the trunk of the body or the arms and legs. There's often something called a vibratory tremor involved, so you might see a very rapid kind of vibratory tremor movement superimposed on the tonic muscle stiffness. They are very often occurring as a child is falling asleep or during sleep, and they're typically brief, like less than a minute or so. The second seizure type is something called an atypical absence seizure. So you might recall from earlier in the conversation the term absence. These are considered atypical absences for a couple of reasons. One is because the degree of interruption of awareness is less than with a typical, like with an absence that occurs with CAE, meaning sometimes children have an ability to interact just a little bit during the seizure, although it's a change from their typical ability to interact. The seizures also last much longer than the absences that are included in CAE or JAE, by which I mean they typically last for several minutes at a time as compared to several seconds. The third type of seizure is something called an atonic seizure, which can sometimes look like a myoclonic seizure, so it's essentially difficult to distinguish just by looking at it. You see that a child or an adult experiences a very sudden, brief muscle twitch or just a fall. You might just see it limited to their head and neck, or their whole body might fall to the ground, which is something that we call a drop attack. This type of epilepsy often leads to seizures that persist for a long period of time, more than 10 minutes, which is something called status epilepticus. About 90% of patients with Lennox-Gastaut syndrome have at least one episode of status epilepticus in their lifetime. All children with Lennox-Gastaut syndrome have developmental delay, typically generalized or global developmental delay, and they are not normally developing. They have intellectual disability as well. Their seizures are typically resistant to treatment with medication, although we certainly do our very best to try to control them or limit them as much as possible, or to limit convulsions or the types of seizures that might cause physical injury to a child. But we see that seizures persist or occur lifelong in over 80% of individuals with Lennox-Gastaut syndrome. It also has, like West syndrome, some characteristic EEG features, and similar to West syndrome, the use of non-standard anti-seizure medications like steroids is important, although we use that less than, let's say, in infantile spasms, relying on more traditional therapies as well. This actually is a very good example, Russ, of a type of epilepsy in which something like a VNS might be something that could be really helpful in terms of reducing the number of seizures that a child is having within a day or a week or a month.
Right, right.
So yeah. And these two, just in terms of their underlying causes, are basically almost all of the, when we were kind of talking about those 6 main subtypes of epilepsy, in theory, any of those could potentially cause West syndrome or Lennox-Gastaut syndrome, although the most common underlying causes are genetic abnormalities and structural changes in the brain that involve the brain diffusely, meaning not just one small area.
Right. Okay, well, I think what we'll do is we'll go ahead and open it up to questions now. Okay, who'd like to get us started with a question?
Hi, this is Kim Streeman. A lot of the ones that we talked about today discuss onset ages of 1 or older. How common is it for kids under the age of 1 to have seizures?
That's a great question. So epilepsy is actually most common for children less than age 2. So it's in the infant time period, essentially, and then eventually there's another peak later on in life in adulthood. But you're exactly right to focus in on the infant time period as important periods of time in a child's life in terms of the frequency with which we do see seizures and epilepsy emerging. Okay. Was there a specific, was there anything else specific to that you were curious about?
No, actually, I have an appointment with you tomorrow. My 9-month-old just started having seizures, so I'm just trying to collect as much information as I can.
Okay. No, I'll tell you what. I really look forward to speaking with you more tomorrow and to answering more specific questions then.
Okay, cool. Thank you.
Other questions?
No problem.
Dr. Shah, thanks for the insights, and I have a question. My name is Shrey, and what are your thoughts about using CBD oil for seizures in kids?
Yeah, it's a great question. You know, we're certainly, as an epilepsy community, always so excited when there's any new tool that allows us to potentially control more seizures and make lives better for children and adults with epilepsy. And so it was with a great deal of excitement that we learned about CBD in its non-FDA approved version, and now even more recently in the FDA approved version called Epidiolex, which received FDA approval, I believe, about a month ago. So essentially it's available for prescription. What we have learned based on the clinical trials that led up to the request for FDA approval, which were done in very specific populations of individuals with epilepsy, mainly children with very severe types of epilepsy, the main ones being children with Lennox-Gastaut syndrome, Dravet syndrome, and tuberous sclerosis. I know we didn't get to talk about Dravet syndrome and tuberous sclerosis specifically before, but if anybody has a question about those, I'm happy to answer. Essentially, what we learned from those clinical trials was that overall, CBD oil or Epidiolex had about the same efficacy in terms of seizure control as any other new type of anti-seizure medication that might be developed, by which I mean it significantly benefited, roughly speaking, 20 to 30, basically 20 to 30% of children experienced a clinically significant decline in their seizures. And so that was an important message because it meant that Epidiolex was not necessarily a panacea, but it was about as helpful as any new other type of anti-seizure medication. We also learned that there are specific clinical scenarios and specific seizure types that are more likely than others to benefit from Epidiolex or CBD oil. We know that convulsive seizures and Lennox-Gastaut syndrome and Dravet syndrome can decrease significantly with those. That atypical absences and there's another type of seizure called a head nod seizure that can be more likely to respond. But we know that medication is less helpful for focal seizures And it doesn't have a role in, let's say, things like the genetic generalized epilepsies that I was mentioning, the types of epilepsies in which we already have so much data about what conventional anti-seizure medications work, and that have such a favorable prognosis overall that using a medication with a very short amount of track record, essentially, and one that does have its own side effects, just like any other medication, it would not be warranted in those specific epilepsy syndromes. So that's kind of what we've learned, and we are in the process of starting to apply it based on a child's the clinical details of their epilepsy.
As a follow-up to that question, have you so far had any, you and your colleagues had any success in getting it covered by insurance for children who don't specifically have Dravet or Lennox-Gastaut?
It's a great question. We have not, actually, and there are a couple of reasons for this. So it was just very recently approved, and there is every insurance company requires prior authorizations to use this medication because of its cost. And so there is paperwork that the doctor's office has to fill out and submit to the insurance company, and they have a process by which they determine whether or not a patient is eligible for the medication. And we have learned that, at least in our experience, they have been pretty strict about refusing to pay for this medication outside of the specific case scenarios that I mentioned before, like the types of epilepsy that were studied in the clinical trials, and that have essentially clinical trial data to back up the use of the medication.
Okay. So other questions?
This is Jean Smith. I came in a little late. I was at work, so I just had a question. Our granddaughter was here in Michigan visiting, and she had a febrile seizure, as we thought. And they went back home to Pennsylvania and was diagnosed. She had more seizures. So, but she was just diagnosed with, is it DOOSE, D-O-O-S-E syndrome? I missed the first half of, well, that's what they think she might have. I actually work over in Beaumont, but so I was really listening. I do, yeah. But they live out of state, but they may be moving back, so I'm kind of researching, trying to find neurologists. But did you speak about that type of syndrome at all, or not in the beginning?
Good question. So we did not speak about DOSE syndrome specifically. It's named after a German neurologist, so there's a slight twist in how it's pronounced. But certainly don't worry about that at all. It's also called it's called myoclonic astatic epilepsy, MAE. That's the other acronym you might hear. So not knowing the specific clinical details of your child's experience, let's just say that the diagnosis of MAE was appropriate. That is a type of epilepsy that has a variable type of onset and a variable prognosis, I would say. It's very common, actually, for children to have initially seizures only in the setting of fever, and you might think initially, they might be diagnosed initially with febrile seizures.
Right, she did have a fever, when it first happened. She did have a slight fever,
Yeah, so it's very common for that to happen, that in an otherwise healthy and normally developing child, when they have a fever, they might have a seizure as well. And so if there's that only thing that's happened, a doctor might make a diagnosis of febrile seizures, as you say, but certainly if there's a pattern that emerges in which a child is having very frequent febrile seizures, or the seizures are happening and there actually isn't a fever, or maybe the temperature is only like 99.8, not a true fever. You have to start to
it was over 100,
Oh, okay.
It was over 100. Yeah, sorry to interrupt.
Yeah,
but, she was totally, normal after that. She actually was born a bone on a redhead, but it came on so violently, though. Yeah, it just. Yeah. And she was fine for a week, and then, but she still has a couple. She's on 2 different medications. I'm not even sure what they are now. But she has a lot of these. My daughter calls them in the morning. These old drops, like she. Her head drops, and so that's how they kind of coined it, that syndrome. But real quick question, I don't want to hold everyone up, but she's actually on the keto diet. They live in, outside of Philly, and she goes to CHOP. And they're very pleased, with their, the doctors there, the neurologist. But this keto diet, I don't know, she's just having a hard time. Julie's totally refusing to eat sometimes. It's been a real problem. Yeah. And my daughter's just trying to. So would you recommend maybe going to, seeing some behavioral type? I don't know. They're kind of stumped. I mean, she makes her all these different foods, and sometimes she's, it's a totally different subject, probably the eating, but she's rebelling, because she doesn't like some of it, but. My daughter's going to the cooking classes, and it's kind of hard to that. But anyways, what would you recommend she do? She's just with them. Sometimes she won't eat, She said, I don't like that, Mommy, But
it's a great question. So the ketogenic diet actually there's very, very high quality and strong data to support its use in MAE, by which I mean it could be very much worth it from the standpoint of seizure control to try to push for ways to make eating more enjoyable and successful again, because the ketogenic diet can have such a profound positive effect.
It has already. I mean,
So, again, not knowing the details, but it could be very, very positive to try to stick that out as long as they're able to. You highlight.
They are. They're not giving up. Oh, yeah. Yeah, she's going to stick with it.
But you highlight a number of important things that can also happen in that experience. When a child has such a profound change in terms of what they're allowed to eat, in terms of the flavor, the texture, the fat content. It's a very big change, and it can take a little while to settle back in. Somebody like a speech therapist can sometimes be helpful, not for a language, but for essentially kind of thinking about the mouth experience, the mouth-based experience of eating, and thinking about making textures more appealing. That can be something. It sounds like your children, I don't know if this is your son or daughter, and their grandchild, but sounds like they're doing great in terms of exploring cooking classes and learning about.
She's gone there, numerous times for the classes, and she loves it, and she's met all kinds of people, but you won't believe what she makes for her. I mean, it's unbelievable. She's I bet. Oh, she spends half the day making stuff. But I'm going there next week, so hopefully we'll see how it's going.
Okay. Well, if I can give any help to your family, just let me know.
I have a young adult child who has not outgrown a childhood epilepsy condition that I was told he should have outgrown before puberty. And he has been switched to an adult neurologist who knows nothing of, has never experienced a patient with the condition that he has. And I do not have a pediatric neurologist I can bring him to anymore. What could you recommend or suggest that I could do for my child?
Yeah, it's a great question. Just out of curiosity, how old is your child now?
He's 18, and he has Landau-Kleffner with CSWS.
Okay, gotcha. Okay, so you were told that he has a childhood absence epilepsy condition, but also the LKS and CSWS. Is that right?
Yeah. He has Landau-Kleffner with the CSWS.
Yeah. So, at age 18, technically, you're kind of somewhere in a gray zone between a pediatric and adult specialist. You can technically still see either one. So, just in terms of resolving that, there could be an expanded group of people if you felt as though a second set of eyes would be helpful. Certainly in a circumstance in which, an individual child or young adult's experience is not what we expected or is atypical, we always have to step back and wonder, was the initial diagnosis made correctly? I admit without having the details of your child's health history, it'd be harder to address that and over the phone, but that's always an important thing, just to step back and say, okay, is this actually the right diagnosis, or is there some other process that maybe looked like it was that, but now that my child is older, I realize maybe this is something else and we need to do other testing. In some ways similar to the previous caller's anecdote about her grandchild, in which, let's say, they might initially have been diagnosed with one thing, like febrile seizures, and then it turns out that was just the beginning of a process that was very different and required different treatment. And so as time passes, if things are changing in a way that is not typical, again, going back to just the drawing board and saying, okay, is this really what I'm working with, is important. Once you're able to do that, it can really help to clarify what therapies can be most successful. Like for LKS, for instance, very different types of medication therapies are needed. Non-traditional anti-convulsants or therapies, again, like steroids, high-dose Valium. There are a number of other types of therapies that can be provided to help address the CSWS and any type of language change associated with that. So that's what I would think of. I know this isn't, if I can help in any way in clinic, I'm happy to as well. Thank you.
Okay,
Thank you.
And I think one more question. Shauna, you had a question?
I just have good evening, Dr. Shaw. My name is Shauna Cahill. I have a 7-month-old son. He has full epilepsy, infantile spasms, and he does have silent seizures as well. The questions I have are more, I guess, geared towards the infantile spasms. We have not told anything about West syndrome as of yet. So I guess my question is when he gets older, is this going to turn into something else? I guess better term, is he going to grow out of it? I guess I'm inquiring of what am I looking at for long term?
Yeah, great question. So you're cutting out there just a little bit, but I think I got the gist of the question. West syndrome or infantile spasms can be caused by a myriad, many different specific underlying causes, and the prognosis or the outcomes are directly linked to the underlying cause. By which I mean it's an umbrella term that includes many, many different types of epilepsy or underlying cause of epilepsy, I should say, within it. And so it's hard, without knowing, again, the details of your son's case, it's a little harder to be able to say with precision what the future might hold.
Okay.
But, thinking about just some of the general clinical things that we know about West syndrome. And sorry, did you mention that he was diagnosed with that, or he was not diagnosed?
No, so far he's not. His last 23-hour EEG, they said that it showed no Hibs arrhythmia. And he is on vigabatrin, which is so far I haven't seen any of the clusters in probably about, I would say about 3-ish weeks now. So I was just wondering, is it long-term, I guess for lack of better terms, is this something that he will grow out of if he's already not been diagnosed with West? Is it still a potential that he could be diagnosed with West?
Well, so typically, if a child is having infantile spasms within the first year of life, and there is any component of developmental change associated with it, we usually consider that West syndrome, although rarely, and again, I'm speaking without knowing too much of the details, rarely you might see infantile spasms in the setting of having focal seizures specifically, and there is not hypsarrhythmia on an EEG, and that's a uncommonly occurring but different scenario. And so if that's the case, the prognosis is different from what you might think of as, more pure, more commonly understood West syndrome. But one of the most important things to be able to identify in that scenario is, where the focal seizure is coming from, and are they coming from a structural, architectural change in the brain, and if so, is that something that would benefit from an epilepsy surgery, because that could potentially be curative. If a child has infantile spasms and hypsarrhythmia and developmental delay, we consider it West syndrome. And the outcomes for those children are very different. We know that having a developmental delay, even after the epilepsy is controlled, is high. It's about 75 to 80%. And we know the likelihood of going on to one day have epilepsy, albeit potentially a different type of epilepsy with other types of seizures, whether it's Lennox-Gastaut syndrome or another type, is also high. And so that would be a different scenario from the first one.
Okay. I guess I kind of answered the next question I have, and this is the last one, I promise. Right now we just see a neurologist. But with everything that my son has going on with the focal epilepsy, the infantile spasms, and silent seizures, in your professional opinion, do you really think that we should be going to see a pediatric epileptologist?
It's a great question, and I know, Russ, this was on your to-do list to talk about. I do, and I say that with no, personal, professional self-interest in mind. Any child with an epileptic encephalopathy or a potential epileptic encephalopathy, like West syndrome or infantile spasms, should definitely see an epileptologist. Other children who should see epileptologists are children who seizures persist despite, one and certainly two seizure medications. So maybe you could wait until you try a second medication if a first medication hasn't completely stopped them, but by the time you're on two medications, you should definitely see an epileptologist.
You're on three.
Children, okay, then definitely. Yeah, definitely. Yeah. And then another group of children who should see epileptologists are any child with focal epilepsy, to understand whether or not they're epilepsy surgery candidates.
Okay.
Because of the time-sensitive nature of the importance of potentially getting them that therapy.
Okay, awesome. Thank you so much for answering my questions. I really appreciate it.
My pleasure. No problem.
Okay, well, thank you again so much for staying on a little later. We really appreciate that. And if anyone does have any additional questions, please do feel free to email them to me, and I can try to answer them, or if I can always send Dr. Shaw an email and see if I can get her input. If I
for sure.
So thank you again, Dr. Shaw, for a really excellent presentation. A daunting task to try and cover so many different epilepsy syndromes, but I think we did a great job. And
really?
And I appreciate everyone for joining us tonight. Again, this will be added to our website, so if anyone wants to go back and listen to it, hopefully by the end of the week I'll have it up. And we will have a new slate of Learn and Share conference calls, probably to be released at some point in January of next year, and I encourage you to look those over and join us for some great calls next year. So again, thanks Dr. Shaw, and thanks everyone for joining us.
Thank you, Dr. Shaw.
My pleasure. Thank you, Russ, and thanks so much to the Epilepsy Foundation. It's always an honor to participate in these meetings, whether in conferences or on the phone. So thank you.
Yes, thank you so much. Agreed.
All right, good night, everybody.